Right, so I'm going to talk about precision medicine inflammatory bowel diseases. And I'm going to start in the next 25 minutes or so. I will provide initially a background on inflammatory bowel diseases, or IBD, for those who are not familiar with the disease. Also, I will highlight the current advances in precision medicine, in particular, identification of biomarkers for prognosis of disease course and response to treatment, and what I believe are the biggest challenges in advancing precision medicine. And finally, I will describe the IBD Plexus, which is the largest research platform to support precision medicine in IBD that the Crohn and Colitis Foundation is building. So inflammatory bowel diseases, or IBD, are chronic inflammatory diseases of the gastrointestinal tract. There are two main diseases. One of the most common ones is Crohn's disease and ulcerative colitis. Crohn's disease is characterized by segmental inflammation that extends to the submucosal layers of the GI tract. It can happen anywhere in the GI tract. Symptoms include no blood, diarrhea, weight loss, and abdominal pain. In contrast, ulcerative colitis is a diffuse inflammation, is limited to the mucosa of the colon and the rectum, and symptoms include bloody diarrhea with pus, fecal urgency, and abdominal cramps. Now, the disease has a very variable course, and as was demonstrated by this 10-year study called the IBSEN study. So they found that 43% of patients have or experience symptom severity that decrease over time. Now, in contrast, 20% of the patients have a continuously active disease with unremitting symptoms, and as shown in yellow. And then in red, you see that 32% of patients have recurrent relapsed symptoms, also basically continuous flaring of the disease. So given this heterogeneous disease course, you can begin to imagine how identification of biomarkers able to stratify patients according to disease severity will be critical to provide personalized treatments for IBD. Now, in this study, they also found that 53% of patients develop complications that require surgery. So the main complications in IBD are strictures, fistulas, and abscesses. So according to the Montreal classification, the persistent inflammatory phenotype is classified as B1. Stricturing complications are classified as B2, and they are characterized by fibrostenosis of the intestinal lumen, and that leads to obstruction on the intestine. And penetrating disease, which is classified as B3, which is characterized by abscesses and fistulas, which basically are abnormal connections of the intestines with itself or with other organs due to perforation of the ulcers. All right, so in terms of the therapy, the most common approach is what is called as the step-up approach, in which patients are treated according to disease severity. So in this case, a patient with a mild symptoms will be treated initially with antibiotics and aminosalicylates. Patients who don't respond to this treatment will be treated with corticoids and immunosuppressants, and in more severe cases, they will be treated with biologics like anti-TNF-alpha antibodies or surgery. Now, what is the problem here? You might be delaying the adequate treatment in a patient that has an aggressive disease. Now, as an approach, there is the top-down approach, in which there is aggressive treatment early in the disease with biologics. Now, problem here, you might overtreat patients and expose them to the cost and the risk of immunosuppression. So you can see again, if you have a stratification biomarkers that can classify patients according to disease severity, then you might be preventing the trial and error of the step-up approach or the unnecessary immunosuppression of the top-down approach. All right, so you can see now what the problem is in IBD. It has a variable disease course. Some patients have more aggressive disease than others. That is characterized by an unremitting disease, recurrent flares, need for drug escalation, and surgery. 50% of patients develop complications. They are very difficult to treat once they develop, and therefore, generally, they require surgery. There is recurrence after the surgery, and they dramatically impair the quality of life of patients, and in some cases, it might be fatal. And another big problem, there is a variable response to treatment. So 30% of patients do not respond to biologics, which are the best therapies available, and for those who respond, 50% of responders lose response over time. All right, so what is the big unmet need in IBD is the early detection, ideally a diagnosis of patients with potential aggressive disease course and the response to treatment, so that doctors can decide the best treatment options that are based on the biological and clinical characteristics of the patient to deliver the right drug to the right patient at the right dose at the right time, which is obviously the core of precision medicine. All right. So to support this concept of precision medicine in IBD, I will provide some examples of very exciting advances in the integration of genotyping together with molecular and clinical phenotyping to identify prognosis biomarkers of aggressive disease course, in particular in disease that is unremitting and complications. And patients that require treatment escalations, as well as the prognostication of response to treatment using biologicals like anti-TNF-alpha or anti-integrin antibodies. All right, so I will show you data related to the identification of genetic risk factors for prognosis and the integration of clinical parameters with molecular phenotyping using transcriptomics and microbiomics. All right, so currently clinicians are using different clinical parameters to try to predict a disabling disease using standard serological markers, using the disease location, complications of diagnosis, and the age and the lifestyle. However, none of these clinical parameters right now are enough to predict how severe the disease is going to be and the response to treatment for a specific patient at diagnosis. So work has been done trying to identify genetic risk factors for IBD prognosis. So basically in the last decade, there has been a discovery of 240 risk loci that are associated with IBD susceptibility. And it has provided a lot of insights into understanding the biology of IBD, in particular regarding the epithelial barrier function, antimicrobial defense, and immune regulation. Now, from all these risk loci, highlighted in red are those that also have been explored as a prognosis biomarkers. So as you can see here, in particular the NOD2 gene, which is regulating microbial recognition, the IRGM, which regulates autophagy, and two regulators of the immune response, the interleukin-23 receptor, and the TNF-SF15. All of these risk variants have been associated with prognosis of stricturing or penetrating complications in European, North American, and Asian cohorts. Now, the big problem here is that still they have a limited effect size that really restricts their use as a standalone biomarkers. Then it has been suggested the idea of using different genetic variants altogether to try to have a better prediction. So recent work from Mass General Hospital, Rami Xavier, have shown that genotyping can be also used for predicting primary no response to anti-TNF-alpha. And as you can see here, they discovered 7 SNPs that are associated with no response to TNF-alpha. And the interesting thing here is that combining these 7 SNPs with clinical parameters, they were able to increase the predicted value with an RC of 0.85. And this is great because just the clinical parameters alone only have a IUC of 0.5 in terms of predicting primary no response. Obviously, we need more larger prospective studies to confirm these findings. In summary, I show you that genotyping has been explored for prognostication in IBD. Several loci have been associated with IBD prognosis and response to treatment. However, the clinical application still is limited, and it has been proposed that a composite risk score might provide an improved predicted value and an effect size. All right. So I'm going to shift gears now to talk about integration of clinical parameters with transcriptomics. In particular, I'm going to describe this very exciting groundbreaking work called the RISK study that was conceived and funded entirely by the Crohn and Colitis Foundation. Groundbreaking work that tried to identify molecular biomarkers or predictors of disease complication in pediatric IBD. This is the largest well-characterized inception cohort of pediatric IBD, 1,000 Crohn's disease patients. Patients obviously were enrolled at diagnosis and before treatment. The aim of this study was to identify clinical and biological predictors of complications, structuring and penetrating disease in Crohn's disease at diagnosis, and evaluate the effect of early anti-TNF-alpha treatment in reducing complications. So methodology: data collection of clinical parameters, antimicrobial serologies, gene expression, microbiome, genotyping, response to treatment. All this data were analyzed using computational tools. More than 80 million data points were analyzed to create a composite risk model to predict complication in pediatric IBD at diagnosis. And a propensity score matching was used for assessing early anti-TNF-alpha efficacy. The results of this work after 3 years follow-up were published in a seminal paper in The Lancet in 2017. And the main outcomes of the 3 years follow-up are the following. Out of the 913 patients that were studied, 835 remain uncomplicated and with a persistent inflammatory phenotype, and 54 patients developed a stricturing disease, and 24 developed fistulas and abscesses penetrating behavior. All right, so that means that 10.7% of the patients developed complications, both penetrating and stricturing disease during the 3 years follow-up. Now, this is the very exciting part. Expression profiling of ileal biopsies using RNA-seq lead to the identification of 2 gene expression signature, one extracellular matrix signature and the other inflammatory signature that can predict complications at diagnosis. So what is fascinating is that the kids that have regulated inflammatory genes at diagnosis went to develop a complication that is inflammatory in nature, namely penetrating disease, abscesses and fistulas. In contrast, those kids that have upregulated extracellular matrix genes at diagnosis went to develop structuring complications, which are characterized by fibrostenosis of the intestinal lumen due to the deposition of extracellular matrix proteins. So this is very exciting because that means that these 2 gene expression signatures might not only be potential biomarkers for predicting complications, but there are also potential drivers of the disease course of the complication and open the doors for identification of new drug targets for precision therapeutics. All right, so in terms of effect of predicting effect of early anti-TNF-alpha in reducing complications, these patients, the kids, were treated within the first 90 days after diagnosis with anti-TNF-alpha therapy, and they were assessed using I forgot the propensity score matching. So as you can see here in red, the early anti-TNF-alpha treatment prevented stricturing complications, basically prevent the inflammatory complication, which is logic. As you remember, those are the kids that have a diagnosis elevated inflammatory signature. Among those, obviously, the TNF-alpha genes that are regulating the pathway. In contrast, the kids that have elevated fibrosis genes, the extracellular matrix, the early anti-TNF-alpha did not prevent the fibrosis. So this is very important because that tells you that maybe these 2 signatures, could be eventually used as companion diagnosis to make early decisions for the treatment of these pediatric patients. All right, so I show you examples of the use of gene expression to prognosticate complications in IBD, in particular stricturing and penetrating complications. But what about prediction early in the disease of an aggressive disease course, a disease course that is continuously active, continuous flaring, the need for treatment escalation? So very exciting work as well coming from the lab of Kenneth Smith in Cambridge. The aim to identify blood-based gene expression signatures for prediction of aggressive disease course. Aggressive disease course was defined as unremitting disease that required treatment escalation. Indolent, in the contrast, indolent disease was characterized by sustained remission and that didn't require therapy escalation. So as you can see here, gene profiling of CD8 T cells lead to the identification of 2 signatures that can be found in ulcerative colitis and Crohn's disease patients, and these signatures can stratify patients in 2 very distinct groups, namely the IBD1 signature in red, that is characterized by elevated gene expression, and the IBD2 signature in blue, which is characterized by lower gene expression of differentially expressed genes. Now, more importantly, when you use these gene classifiers, you find that those that express the IBD1 signature had a more aggressive disease that required treatment escalation. In contrast, those patients with the IBD2 signature had a less aggressive disease and less need of treatment escalation. So these are, as you can see, potential gene classifiers or gene expression classifiers that can tell the doctor whether to initiate with biologics those patients with the IBD1 signature, the ones that potentially have an aggressive disease, and probably use a step-up approach for those who have the IBD2 signature. Now, the utility of these classifiers is currently being evaluated in a randomized controlled trial in the UK, which is the PROFILE study. All right, so show you examples of gene expression for prognostication of IBD complications, prognostication of an aggressive disease course that requires treatment escalation. What about response to treatment? As well, exciting work from Fiona Spiori lab in Oxford. She showed that the cytokine or oncostatin M is highly expressed in IBD mucosa, and the higher the expression, the more severe the disease is, and this is based on histological score. Now, what is very important here is that to check whether this oncostatin M could be related to response to anti-TNF alpha, they found that before treatment with infliximab, patients that did not respond to anti-TNF alpha had already elevated levels of oncostatin M, as you can see in red. And as expected, 8 weeks after treatment with infliximab, those patients that didn't respond remain having high levels of oncostatin M. All right. So I show you examples of gene expression signatures that can eventually be used for early prognosis of complications using the risk study signatures, also the IBD1 and the IBD2 signatures to predict aggressive disease course, and response to treatment using the oncostatin M and probably the ECM and inflammatory signatures from the risk study. So obviously we require more randomized controlled trials to really evaluate the utility of these signatures so that doctors can decide early the best personalized treatment options for patients with IBD. All right, so now I'm going to shift gears to work related to the integration of clinical parameters with microbiomics. So the risk study I just mentioned not only evaluated gene expression signatures, but they also evaluated changes in the gut microbiome. As you can see, sorry, in the upper panel, 2 taxa, Ruminococcus and Rothia, were associated with developing of stricturing complications, and in Colicella and Bellionella in the lower panel were associated with penetrating complications. So that means that not only gene expression signatures, but probably integration with the microbiome signatures can be used in this composite risk model. Now, in regard to the use of microbiome-based signatures to predict response to treatment, work from Ragmi Xavier at MGH analyzed the PRISM cohort to evaluate the response to anti-integrin. The response was defined as clinical remission at week 14. So as you can see here, 5 taxa were decreased in responders after 14 weeks, and 17 microbial metabolic pathways were downregulated in patients that responded. Interestingly, these patients have 13 of these pathways upregulated and diagnosis, which means that this treatment is changing that pattern of metabolic pathways. All right, even more important in this study was that using artificial intelligence with neural network analysis, they integrated clinical parameters with microbial signatures, both the taxonomic and the functional microbial signatures, and they were able to increase the predicted value of this model with an AUC of 0.87. In contrast, the clinical parameters alone had an AUC of 0.6. So you can see the value of integrating clinical data with multi-omics analysis. All right, so I'll show you examples of gene expression and microbiome prognostic signatures to predict complications, aggressive disease course, and response to treatment, in particular to biologics. All right, so you can see this is just an example of how the clinical phenotyping is just the tip of the iceberg in IBD prognosis and treatment. So we have to go beyond only clinical parameters and integrate multi-omics data to better characterize and phenotype the patients, and not only genotype, genomics, transcriptomics, but all the omics are important. And a lot of this work is also being conducted in IBD, including also molecular endoscopy. All right, so what are the challenges for precision medicine in IBD? Obviously, data collection and integration. There is a huge need for harmonized data and sample collection, and I think that's common for all therapeutic areas. The need for multi-omics integration and the integration of these multi-omics with electronic health records, the development of artificial intelligence tools. Now we have the other big challenge is that we have obviously some biomarkers that academic labs are starting to discover, but obviously we need validation in longitudinal cohorts and inception cohorts that are ethnically diverse. And finally, as you all know, the need for clinical utility studies in a rigorous randomized controlled trials to demonstrate improvements of the patient outcomes in a cost-effective manner. All right, so to address these challenges, the Crohn's and Colitis Foundation is building the largest IBD repository of biosamples and patient data. We have 4 cohorts, about 40,000 patients, and what it provides is that we have harmonized protocols to enroll patients and to collect samples. Those samples are going to be collected, converted into multi-omics data and integrated with electronic health records. So what we provide with the IBD Plexus is a biobank. We provide data analytic platforms to integrate the data, the clinical data with the multi-omics data, and a central reference lab where all the samples are going to convert it into multi-omics data with the highest industry standards. We also provide a high-performance computer for data analysis and a research portal for mining the data and access the data. All right, so as I mentioned, there are 4 cohorts in this platform, 2 virtual cohorts that collect patient-reported outcomes and quality of care data. This is IBD Quorus and IBD Partners. We have enrolled already 20,000 patients. And there are the adult prospective cohort. This is prospective and longitudinal, which is important. A lot of biomarkers are based sometimes in a one data point or retrospective studies. This is very important. It's going to be longitudinal data collection. And then we have the risk cohort, which is the pediatric inception cohort I just mentioned. All right, so SPARK, we aim to recruit 7,000 patients by 2020. It's longitudinal and prospective, which is critical for biomarker discovery. Clinical data and biosamples are collected. Risk cohort is an inception cohort, 1,000 Crohn's disease patients. We have followed them for 5 years, and we are up to 8 years. And clinical data and biosamples are also collected. All right, so in conclusion, several advances have been made in the last decade to integrate genotyping and deep clinical molecular phenotyping for IBD prognosis. In particular, signatures based on gene expression and microbiome have been discovered that can eventually predict complications, in particular stricturing and penetrating complications as early as in diagnosis. Also, these gene expression signatures might help identify early in the disease an aggressive disease that require treatment escalation that is characterized by continuous flaring, and they can be also used for the prediction of treatment response to biologics. Now, what is important here is that if these signatures are validated and implemented, that will help doctors to decide a diagnosis and with precision in which patients to implement a step-up approach or a top-down approach, so that you avoid the trial and error of the step-up approach or unnecessary immunosuppression of the top-down approach. Also, I show you that several of these signatures are potential drivers of the disease that opens the doors for identification of drug targets for precision therapeutics. All right, so all this research, together with the research that is going to be derived from the unprecedented IBD Plexus platform, is paving the path towards precision medicine, and obviously more work is required.